Most people think swollen legs are a standing problem. You were on your feet all day, you ate too much salt, you sat too long on a flight. Rest up, elevate, drink water, and it goes away. That is what most people assume. But the real danger is not the swelling you see after a long day. It is the swelling that keeps coming back, or the swelling that appears for no obvious reason, or the swelling that arrives in only one leg. That is a completely different story. So, the question you should actually be asking is not, how do I get rid of this fluid? The question is, what is your body trying to tell you? And is it something that will wait? If you want more breakdowns like this one, clear, no nonsense health science explained in plain language, subscribe to this channel and join our Telegram community where we go deeper on topics just like this one. The link is in the description. Now, let us talk about what is actually happening inside your legs when they swell. Your body runs a constant hydraulic operation. Blood flows out from your heart through arteries, delivers oxygen to tissues, and then has to find its way back. The return journey depends heavily on two systems: your veins, which carry blood upward against gravity, and your lymphatic system, which drains excess fluid from your tissues. Both of these systems are working against physics every single second you are upright. Think of your leg veins like a long garden hose standing on end, with tiny one way valves every few centimeters keeping the fluid from sliding back down. When those valves fail, or when the pump, your heart, is not generating enough pressure, or when the drainage channels are blocked, fluid leaks out of the vessels and floods the surrounding tissue. That is edema. That is swollen legs. The surface level explanation is almost always too much fluid. But that is like saying a flooded basement is caused by too much water. It tells you nothing about whether the pipe burst, the sump pump failed, or it rained for 3 days straight. Studies keep showing the same thing. Identical looking swelling in two different patients can have five completely different root causes, and the treatment for one can be dangerous for another. Here are the five causes you need to understand. The first is venous insufficiency. This is the most common cause of chronic leg swelling, especially in people over 50. The valves inside your leg veins wear out over time. Imagine a series of trapdoors that stop closing all the way. Blood pools in the lower leg, pressure builds inside the vessel, and fluid is pushed out into the tissue. You will often see this paired with varicose veins, a heaviness or aching sensation, and swelling that is worst at the end of the day and better in the morning after lying flat. It is rarely life threatening, but left unmanaged for years, it can lead to skin changes, ulcers, and serious infections. The second cause is heart failure. When the heart is not pumping efficiently, particularly the right side, pressure backs up through the venous system. The body retains sodium and water as a compensatory mechanism. The result is bilateral swelling, meaning both legs, often moving upward over time. This is one of the reasons bilateral swelling should never be casually dismissed. Meta analyses in cardiology journals consistently identify new or worsening leg swelling as one of the earliest signs of decompensating heart failure, often appearing before the patient feels noticeably short of breath. The third cause is kidney disease. Your kidneys regulate how much fluid your body holds. When kidney function drops, protein can leak into the urine, and when blood protein levels fall, the vessels lose their ability to hold fluid inside. Think of proteins as the walls of a dam. Without them, water seeps through everywhere. You end up with generalized swelling, often starting in the legs and feet, sometimes around the eyes in the morning. This type of swelling, called nephrotic edema, looks the same on the outside as every other type, but the treatment is entirely different. The fourth cause is deep vein thrombosis or DVT. This is the one that cannot wait. A blood clot inside a deep leg vein blocks venous drainage on one side, causing sudden, often painful swelling in a single leg. The danger is not the swelling itself. It is that a piece of that clot can break off and travel to the lungs, a pulmonary embolism, which can be fatal within minutes. One sided swelling, especially if accompanied by warmth, redness, or calf tenderness, is a reason to go to an emergency room today, not tomorrow, today. The fifth cause is lymphedema. Your lymphatic system is a parallel drainage network running alongside your blood vessels. When it is damaged by infection, by cancer treatment, by surgery, or sometimes for no clear reason, fluid accumulates in the tissue and does not drain. Lymphedema produces a thicker, more fibrous type of swelling. Press your finger into the skin. If the dent stays for more than a few seconds, that is pitting edema. And while it can appear in other types too, persistent non pitting swelling that hardens the tissue over time points strongly toward lymphatic involvement. You might assume that if you identify the swelling early and manage it aggressively, you can prevent all downstream consequences. That is not exactly right. Two people with identical amounts of leg swelling, identical lab values, and identical heart function can have wildly different outcomes depending on how long the underlying cause has been present, whether they have diabetes or inflammatory disease layered on top, and how their individual vascular anatomy responds to pressure. That is why you can never read your real risk of the swelling alone. Now, let us talk about what you can actually do. The first and most universal tool is compression. Graduated compression stockings apply external pressure that mimics the muscular squeeze your calf produces when you walk. They physically push fluid back into the venous system. Meta analysis in vascular medicine show consistent benefit for venous insufficiency and post DVT management. The practical use case: if your swelling is mild to moderate, worse at the end of the day, and your doctor has ruled out acute causes, properly fitted compression stockings, 20 to 30 millimeters of mercury for most people, are often the single most effective non pharmacological intervention available. The second tool is elevation. Straightforward physics. When you lie down with your legs above the level of your heart, gravity does the work your veins cannot. 30 minutes in the morning and 30 minutes in the evening can meaningfully reduce chronic venous edema. It is unglamorous, it is also effective. For heart related swelling, the primary pharmacological tools are diuretics, medications that tell the kidneys to excrete more sodium and water. Loop diuretics like furosemide have decades of data behind them in heart failure management. Large randomized trials show they reduce hospitalization and relieve symptoms. The practical use case: they are titrated carefully because pulling too much fluid out too quickly can drop blood pressure and damage the kidneys. This is not something to self manage. For DVT, anticoagulants are the cornerstone of treatment. Newer direct oral anticoagulants, drugs like rivaroxaban and apixaban, have largely replaced older blood thinners in many patients based on large outcome trials in hematology. The use case is clear: prevent clot extension and embolism. Duration of therapy depends on whether the DVT was provoked or unprovoked, and that is a nuanced conversation for your physician. For lymphedema, the most evidence backed approach is complete decongestive therapy, a combination of manual lymphatic drainage, compression bandaging, exercise, and skin care. It requires a trained therapist and commitment. There is emerging research on pharmaceutical options for certain genetic forms of lymphedema, but that field is still developing. Now, two patient stories that make this concrete. Gary is in his late 50s. He has been a smoker for 30 years, works long shifts on his feet, and has noticed that his ankles swell by evening. He assumes it is the job. His doctor mentions his blood pressure is high, his cholesterol is borderline, and there is mild protein in his urine. But Gary is not in pain, so he moves on. Over 4 years, he ignores every single marker. One night, he wakes up unable to breathe, lying flat. Emergency room, acute heart failure. His chart tells a story of 5 years of compounding vascular damage that expressed itself in his ankles long before it reached his heart. The lesson: swelling is not always the problem. Sometimes it is the earliest line in a longer chapter. Linda is in her late 40s. She has no history of heart disease, does not smoke, and keeps her weight in a healthy range. After a long overseas flight, she notices one calf is swollen and tender. She assumes she slept on it funny on the plane. She takes ibuprofen and waits. 3 days later, she collapses at work. Pulmonary embolism from an undetected DVT. She survives, but barely. Linda's story is a reminder that one sided swelling after immobility is not a muscle cramp until it has been ruled out by ultrasound. The lesson: the absence of obvious risk factors is not the same as the absence of risk. Here is what you do next. First, pay attention to the pattern. Is it both legs or one? Is it worse at the end of the day or constant? Is there pain, warmth, or redness? One sided, sudden, painful swelling goes to emergency care immediately. Bilateral, gradual, painless swelling starts with your primary care physician. Second, ask your doctor for a fuller picture. Swelling alone is not a diagnosis. A proper workup might include a BNP or NT-proBNP to check heart stress, a metabolic panel for kidney function, a urine protein test, and a lower extremity Doppler ultrasound if DVT is suspected. Do not accept it is probably nothing without at least a basic panel. Third, be honest about your habits. Sodium intake, alcohol, how much you actually move, whether you sit for hours at a time. All of these modulate fluid retention in real and measurable ways. Your doctor cannot manage what they do not know. Fourth, if you are already on medication for a related condition, blood pressure, diabetes, or inflammation, ask specifically whether your current medication can contribute to fluid retention. Several common drugs, including calcium channel blockers and certain steroids, are well known causes of lower extremity edema. This is a solvable problem if it is identified. Fifth, do the unglamorous daily stuff. Walk, use the stairs, flex your calves when you are sitting. Wear your compression stockings before you put your feet on the floor in the morning, not after the swelling has already built. These are small mechanical actions with real cumulative effects on venous return. Your job is not to walk out with a prescription or refuse one out of principle. Your job is to understand what is actually happening inside your body, so that when you sit across from your doctor, you are a partner in that conversation, not a passenger. This is educational content, not a treatment plan. Anything you decide to change about your health is something to work out with a person who knows you, your history, and your actual lab results. If this breakdown helped you think more clearly about what your body might be telling you, subscribe to this channel and join our Telegram community. The link is below. We do this kind of deep dive every week.